So so the strong procedure, I think, leaves, there's two problems with the strong procedure. One is even in the best studies, there's about a 20% recurrence rate because there's still a kink there. And I've seen if there's some inflammation, the duodenum can kind of suck back underneath the SMA and get reobstructed. When you add an anastomosis to that, I think it probably relieves that, but that's essentially what I do, what Dr. Stevenson does. Very similar to kind of what we're doing now.
Okay. And what is the range of angle that suggests SMAS?
I think I've seen a whole wide range of angles, and it can be very difficult to measure because if you think about it, when the SMA comes off, it's actually it's curved, and so it's hard to extrapolate a straight line on top of it. And I don't think it's reliable, but I think the aortomesenteric distance is really the number I go with. That seems to be the most reliable thing that correlates with symptoms.
Okay. And somebody wants to know how often do you see constant burping that can go on for hours and hours and what causes that?
Burping would be a combination of two things. You have some sort of reason the gas is not moving forward, so there could be an obstruction, such as SMA syndrome, gastroparesis, gastritosis. But it would be combined with something called aerophagia or swallowing air. So burps are almost always from air that's swallowed. Um, if you have there's a lot of things that can cause it, but if you have chronic nausea or vomiting, the muscles in your neck kind of don't necessarily can kind of get discoordinated. Instead of keeping air out, when you swallow, the air will come down, and it would be worsened by things the kind of things that patients do to overcome SMA syndrome, such as go to a pure liquid diet, only drink thin stuff. That can potentially contribute to constant burping. So the things I would recommend to just alleviate that are like don't drink out of straws, don't chew ice, get some speech therapy to work on swallowing, and then find out why gas and liquids aren't moving forward.
Okay. And I know the alveolar procedure moves the cecum up to the left upper quadrant. That's not part of your procedure, is that correct?
I don't I that is correct. I don't move the colon at all.
Okay. And I think that's all I have here.
Mhm.
Oh, wait, let's see. What um what are the practical differences between the alveolar and your procedure?
So the alveolar procedure does not completely transect the small intestine. It kind of bypasses the inherent kink when you derotate, and then it also moves the colon as well as the small intestine, I think, unnecessarily. And in my practice, patients that have had that, it's based on the LADS procedure for intestinal malrotation.
Right.
Dr. Alviar was a pediatric surgeon, and so he did a bunch of LADS procedures, and much like I took the things that I did and used them for a new diagnosis, he took the things he was used to and used it for this diagnosis. And I think he obviously drove the field forward significantly by figuring out a better solution. Um, but I've operated on a lot of patients that have had LADS procedures in the past, and they get a lot of adhesions. And in my mind, moving around the intestine that much is, number one, not necessary and can create other problems. But that's, again, I talked to Dr. Stevenson, who does his form of the alveolar procedure, and we will just straight up tell each other, yeah, I don't know which one's better.
Okay. And can SMAS get better but keep coming back multiple times over decades?
Oh, absolutely. Yeah. So, I've met a lot of really kind of patients that inspire me that are suffering with constant nausea, vomiting, abdominal pain. They figure out how to, like, make whatever smoothie they can make to barely function, and they do it for years, decades, and they somehow stay alive. And I interact with, when I talk to them, they go to the doctor. The doctor tells them all you have to do is eat more. They say, it hurts when I eat, and that's why I can't eat. and they just keep pushing through and pushing through. And those patients will put on enough weight, they get better, they create enough fat that the SMA angle opens up a little bit, they start eating again, but the next time they get the flu or a cold or some other illness, they lose a little bit, losing 5 pounds in somebody who's already pretty thin is a massive problem. And then the symptoms recur. And then once they recur, you've got an obstruction. It's hard to eat. You have to push through it. And I've seen patients deal with this for decades.
Okay. And what would you say, what percentage of your patients have connective tissue disorders? Would you know?
Um, just off the top of my head, it's somewhere in the 80-90% range.
Wow.
Yeah.
What about autoimmune disorders? Do you see anything, other connections?
Uh, Maybe a few patients with things like Crohn's. Not a whole lot of true, well-defined autoimmune gastric disorders. There's obviously a lot of mast cell activation syndromes um, that can overlap and probably contribute to the weight loss in the first place. But as far as pure autoimmune lymphocyte-mediated syndromes, relatively just a handful.
Okay. If a surgeon says they only do the DJ, should we get other opinions or options?
I would personally recommend that, yeah, that someone should probably consider all of their options before proceeding with a procedure and understand the risk benefits and alternatives to what they're going to go through, because this is going to be a big deal. And like I said, if you get the lap DJ and you still have symptoms, it's not entirely clear to me that you're going to have a great outcome if you have another operation.
Okay. And here's what dietary recommendations do you give to patients with SMAS? And based on your experience, are there specific food groups that tend to be better tolerated?
Um, Typically, low residual stuff, probably not going to tolerate a salad. You're probably not going to tolerate a steak. But if you can tolerate dairy products, there are a lot of, Ensure, Boost, things like that. There are non-dairy options like Cape Farms makes, and for since this is a educational thing, I will say, as a declaration of conflict of interest. I have no stock. I have no correlation to any nutrition companies. Um, so, you know, basically anything with sugar and high calorie stuff in it. Like if you can tolerate ice cream, it's like go ahead, eat ice cream. Basically anything you want. But to be honest, when I talk to patients, I probably learn more from them about what will pass through than I can give them advice on. And so I just ask everyone, how did you manage to stay alive for the last 10 years? Use that information and then pass it on to the next person struggling.
Right. Have you seen anybody where their SMAS has gotten better by itself?
Yes.
And was that all strictly by weight gain, or was it just by with time and body change growing?
Uh,
Or
one is weight gain. I've had a handful of patients now who very clearly describe a correlation with particularly female hormones, like when they get on one type of birth control, if when they take birth control, their symptoms get worse. And that probably has to do with the hormonal regulation of where your fat is laid down. So testosterone makes your fat, on the inside, and progesterone can make your fat lay down on the outside rather than the inside. So you stay thin on the inside. So had a handful of patients where modification uh, of um, of hormonal therapy can be effective.
that's
Uh,
interesting.
I've had one patient, really just one patient, who basically ate. She just forced herself. I mean, she managed to force herself to eat and gain some weight, and then described basically resolution of symptoms, that she's finally eating again, and now she can eat. Her diet is broadened, and now then it's easier to keep the weight off.
In
Uh,
your experience, how much weight would that be?
I mean, it depends on the patient. Most patients, you're talking about a very little amount of fat that really has to change. So I've had patients that can detect changes in symptoms with probably a 5 pound weight loss.
Okay, I think Stacy has a question.
Okay. There is a surgeon over in the UK, and he's now doing supposedly a new surgery that bypasses the compression of at the DJ at the compression. Anyway, it's a he cauterizes D at D2, and then he does a Roux Y DJ with a jejunostomy.
So he cauterizes the second portion and then does what?
A Roux Y, so it's a Roux Y,
Why?
and it's a
Uh-huh.
duodenojejunostomy with
Mhm.
a jejunojejunostomy.
Um, yeah, I've seen one patient that had that procedure as a revision of a gastrojejunostomy, and she did not get better, and then she did not get better when I kind of did my version of that, resected all the stuff that was underneath the duodenum. So but she also had a component of gastroparesis, so it was very difficult to tell. I think that procedure is going to leave the it's going to leave the duodenal compression in place, but it'll be functionally very similar to a lap DJ.
He
Go.
said he says it it avoids a blind loop. I I don't know, but I would think that you would have like a circular
Mhm.
drainage, circular thing going on, which
It
we
would be, it is a very circular thing, and I don't, I would, um, that would not be, let's just say, it's not, if I think there's a better operation, I would be happy to try it. I don't intuitively think that would be a great operation. If
right.
he does it and shows great results, I'm more than happy. I would be happy to adopt it. I think it has some rationale, but in my experience, the one patient I've seen with that anatomy did not get better.
Go
Yeah.
to bed.
Okay, I'll go to bed. Thank you.
Oh, sorry.
Looks like Julia has her hand up.
Yes. Thank you, Dr. Stevenson, for answering our questions. And you did answer, I asked the one about the scoliosis and
Mhm.
um, the long-term results on the duodenum with SMA.
Mhm.
How much of the duodenum can you resect and what is function like? I'm the one who has like a tortuous, what has been called through the EGDs done to place my NJ tubes, a tortuous duodenum with extrinsic compression on it. And actually, the third portion has migrated now and is no longer up in the angle.
Mhm.
But I have all the symptoms and I can't tolerate anything but liquids now.
Mhm.
What would happen? Like, how much of the duodenum can you go without?
You can remove the entire duodenum. So when patients with pancreatic cancer or duodenal cancer, you can resect the entirety of the duodenum and you can still function. Um, those patients really don't have much loss of function other than maybe a need for some vitamin supplementations. But the absorptive capacity of the duodenum is it does very little absorption. It mainly functions to help regulate, it helps your body understand kind of what you're eating. So it senses like if there's starch present, it'll help your pancreas, secrete insulin, things like that. And its main function is to help mix the digestive enzymes in the bile from the liver and the pancreas into the, newly digested food.
So you wouldn't be missing those, like say enzymes. Will you get them either further up or further down in the system? As
Yeah.
far as that empty, are there ducts that empty into the duodenum?
So if you had your duodenum resected, you'd have to sew the jejunum directly to the pancreas and directly to the bile duct. That's called a Whipple procedure. I don't particularly do that because I don't manage pancreatic cancer. It's kind of its own specialty. So I typically stay away. I don't get involved in that, but I do take care of patients in the ICU, and I've seen patients that have had that as part of my training, and they can, if they survive the pancreatic cancer, they typically have pretty reasonable function long term.
Thank you.
Sure.
I wanted to add that in regards to Stacy's question about the UK surgeon and the Roux-en-Y, somebody has clarified here that there is no blind loop and the compression is released. The UK surgeon said it's an end-to-end anastomosis and they cut it where the compression is. I don't know if that makes a difference, but I just want to clarify that.
Yeah, we didn't say it was a blind loop, said circular loop.
Okay.
Circular.
Yeah, I have to see exactly what he was doing.
Yeah, I'll
'Cause
send it. I'll send it to you.
cochlearization can basically go all the way to ligament of Treitz. So it just depends on exactly how he's constructing it. But based on the description, it sounds like it would be a circular thing.
Mhm.
That's the patient I've seen. I've seen a patient that had that anatomy. Michael?
Could you just explain, you mentioned earlier the difference between your procedure and the alveolar procedure. Could you just explain that one more time? I just want to make sure I understand because you two seem to be the sort of leading practitioners of this. And it's you said you collaborate and compare notes. So I'm just curious what the difference is.
I've had the opportunity to speak to Dr. Alvear one time.
Or I should say Stevenson, I guess, is really kind of
Yeah, I
taken.
talked
Yeah.
to Jacob, to Dr. Stevenson. We probably about once a month kind of just put our heads together. Looks like my computer wants to use Bing. Okay, hold on. It's gonna Dr. Alvear's procedure is gonna leave the intestine kind of in this conformation. So the duodenum no longer passes under the SMA and goes straight down. All the small intestine will be on the right side of the body, and the colon is then moved to the left side of the body. Historically, Dr. Ladd's procedure also removed the appendix because it's in a position that can lead to confusion of someone presenting with appendicitis where the appendix is not in the right side and would lead to confusion. So historically, they took the appendix out. That's kind of a minor point, but it comes up in questions frequently. And then so when you do the Ladd's procedure on someone that doesn't have malrotation, this curve here, can y'all see my screen? So this curve here actually becomes very tight and actually kinks. And so Dr. Alvear connects this part with this part to bypass that kink. And Dr. Stevenson has his own kind of version of doing that it sounds like makes a little more anatomic sense to me, but y'all probably are going to talk to him at some point, so I'll let him describe his procedure. But I don't move the small intestine around. I just, other than the very first part of it, I bring it over to this side underneath the colon. And I leave the colon where it's supposed to be, which is, over on this side. So the colon stays in place. The small intestine is only moved from the very first part of the jejunum. Is swing it over to the right and then make it go straight down, kind of like this, and then everything else stays in place.
Yeah, I mean, yours seems simpler. Like, why do they not agree, or what is the benefit of doing it their way, do you think?
Well, like I said, Dr. Stevenson and Dr. Alvear are both pediatric surgeons, and they do more Ladd's procedures probably than they do, because historically nobody's got a very large cohort of patients in any of these procedures. So my guess is that they just basically took the Ladd's procedure, which would work for duodenal derotation. Dr. Alvear adapted his additional anastomosis to fix that kinking problem, and then that procedure, it makes sense that it would work, especially in younger kids. It makes a lot of sense that it would work. I just think it's more surgery than is necessary, but they took what they do and adapted it to a different problem, and I took what I do and adapted it to this problem, and so that's how we came to kind of a similar convergent solution from two different strategies. And we don't know necessarily is moving the small intestine around necessary. Does moving the colon help? I don't know. We don't have any good comparative studies.
And what would you say is your like typical or average surgical outcome? Like, I know every case is different and some are really complicated. But if you take a typical case and typical outcome, you see what level of symptom, improvement or description from the patients?
So, I mean, I can give you the spectrum. I remember there was a 19-year-old young lady that had, moderate symptoms. She had operated on her on Friday night. On Monday, I came in and she had an empty box of pizza by her bed and wanted to leave. Um, I've had patients that got no relief whatsoever from symptoms, presumably because they had some underlying GI disorder that contributed to their symptoms more than the obstructive problem did. And every evaluation they've had of the anastomosis shows it's open, there's not a blockage, but there's clearly something wrong. There's something else going on with the GI tract. I'd say about 80% of patients, if you look at them long term, months to a year later, 80% are kind of eating whatever they want. Um, with minimal symptoms, occasional vomiting maybe, but like they can eat whatever they want. Um, the That's about 80%. About of those 80%, about half probably get better in a matter of days, and about half take a month or more. I had a lady that came in from out of town. She had to stay in an Airbnb getting kind of TPN for about 6 weeks. And then one day she just started eating again and came to clinic and she was putting on weight. I pulled out her line and she went home much better. So I think I would expect there's a chance you're going to have a very delayed return of gastric function or intestinal function, and there's a chance you're going to have um, a pretty good quick recovery. And then I think there's a small chance that the other underlying problems are actually causing the dominant cause of your symptoms. And so I've tried to start counseling patients with, now that I've got more actual data, I can give more data so a more informed decision could be made.
And how many of these have you done total?
It's about 45, I think 45 last when I entered the my in the database last time I put it in, like 2 weeks ago.
Well, those are great outcomes. It must be very rewarding for you as a surgeon to see that level of improvement in people that have been suffering that much for so long.
Yeah, it is very rewarding. It's a little difficult when the patients have the slow outcomes or the failure to really feel better. I struggle with those, but it is extremely rewarding when patients do get better. And I love hearing from patients that get better. Um, but I try to, patients that don't get better, try and help coach them through it. There's a lot of things about big operations that you get this surge of pain and in adrenaline. You get epinephrine, norepinephrine secreted into your body, so you get this big high the first 2 days dealing with the pain, and then when your epinephrine and norepinephrine levels drop, you get this depression, and then if you're depressed from that letdown combined with not a quick recovery of ability to eat, it can really cause patients to be distressed for that month or so while you're waiting for things to get better. All right, Laura.
Yeah, thanks. So, it was really useful for me to see like the images when you explained the difference between your procedure and the alveolar procedure. I was wondering if you maybe could show me the difference between your procedure and the laparoscopic duodenostomy with some images so that I better understand what the difference is and what my doctor is going to do to me.
Sure. So let's just say this is the SMA instead of recurrent tumor, because this is actually a pretty good picture of it. So, this is your esophagus, your stomach is a bag, kind of stores up chewed up food, churns it over and over into a liquid. So once it's a liquid, it empties into the duodenum. If there's an obstruction, things back up into the duodenum, then the stomach. So, what was very popular a few years ago before long-term outcomes came out was they would take the jejunum and just sew it to the duodenum from the sides. And that's a quick, easy procedure. It makes anatomic sense that now food can come in and then go straight this way. The downside is there's still a blockage here, and then there's this blind loop. If you look at some people describe good outcomes from this, but I think one of the better studies that have come out where people are followed up and asked detailed questions a year later, they seem to still have symptoms. And we don't know exactly why, but we think it's probably because there's still this compression plus this blind loop. Maybe they get some resolution of symptoms, but they certainly still have described problems.
And if you release the ligament there, would that make any difference? Would that be like a good duo?
It would be unnecessary, or it would not. I think if you release the ligament and then just pull it out, you don't have to not only release the ligament, you actually have to pull the intestine out from under the SMA, and that involves flipping the intestine 180 degrees, and that's one of the reasons Dr. Alvear used the LADS procedure. And that the strong procedure is essentially pulling the intestine out and trying to straighten it up. And then that this anastomosis would functionally be very similar to the alvear if you had all of that done without the complication. But I would, I've done this a handful of times, and when I was trying to figure out the right strategy, and I think patients got a little better, but not an adequate. What I would say is enough resolution to have to be happy about it.
Okay, and can you show there in that picture? So what is your procedure? What actually you do?
So I take this, I completely mobilize all of this, the ligamentotrites and everything, and then I swing it over. I cut this chunk out, and I swing the duodenum over to the right, and I take the jejunum and just the jejunum is very floppy. It's not attached to the back. So it's free. And so I just move that over and sew it as a straight tube. So basically all this is gone. I don't have to resect all of this, but it ends up being a straight shot, straight down.
Okay. Okay. Thank you.
You're welcome.
Stacy, how are we doing for time?
Right. That's up to the doctor. He's the one.
I've set aside, I've got plenty of time.
Okay, I have a few more questions on this list here. Somebody would like to know, have you seen any DJ revisions that improved?
Not completely.
Okay, that's a shame. Let's see. And here's somebody who had a nephrectomy, still has SMAS. She has a distance of 5. She's symptomatic, and she wants to know, are there any negative effects of just doing nothing for mild to moderate SMAS, or does it cause problems down the road?
I think if you have mild to moderate symptoms, you can typically kind of, what I would say, eat through them. I don't remember exactly where the pictures are, but they're the pictures online of the way to medically manage SMA syndrome involving like positioning. I just imagine, if you're out at your neighborhood restaurant with your friends and you say, sorry, I'm going to have to get under the table curled up in the fetal position for a little while. Y'all just ignore me. That's not really a functional way to live. And I would call that probably, if you're really having to do that all the time, that would be moderate to severe. Patients that get some discomfort, reflux, things like that, I think I generally recommend attempted weight gain. But some of those patients, even with relatively mild symptoms, when they consider all the options, they say, you know what, I'd rather just have an operation. And if they have anatomic evidence, they usually would typically offer that unless there's some other, medical comorbidity. If they're a good surgical risk, I would offer even for relatively mild symptoms. And again, because those patients are typically the ones that get better quickly.
Okay, thank you. And in your experience, then somebody who's got, um, you know, fairly symptomatic SMAS who's had it for a long time, do you see progressive intestinal damage from that, from having a longer term compression?
Yeah, absolutely. I think those patients tend to not, the stomach gets dilated. Um, they develop essentially a PTSD of eating, where if your brain's been trained for years that every time I eat it hurts, you're going to have a food aversion. That's not a I think as you guys know, a lot of patients with SMA syndrome get labeled with eating disorders, and it kind of is an eating disorder because it hurts when you eat and therefore you don't eat. It's like, but that's not really what we mean by, food aversion. The food aversion is not something the food aversion associated with SMA syndrome is something that's trained in the lower part of your brain, and you have to think about it to overcome. It's not something where you have some sort of, pathology where you don't want to look a certain way, you want to weigh a certain weight, and that it's not anorexia. It's more like a trained response that it's always hurt when I've eaten, and so some patients with a really long um, history of symptoms will very frequently have food aversion and some anatomic problem due to just kind of a big boggy stomach doesn't push things through as well. And so in those patients, I typically counsel them small frequent meals, behavioral therapy, to just retrain your brain. And then I think that's probably beneficial. Don't have any good data to say that helps a whole lot, but it makes the most sense.
Okay, thank you. And here's somebody who's got a common trunk of the SMA and celiac artery. Have you seen anything like that? And how do you think it would affect surgery outcome?
Um, I, yeah, I see it. You see it every once in a while. It's pretty rare. That vascular malformation. Um, I think that I would be very careful to ensure that it wasn't some sort of median arcuate ligament syndrome. I'd probably get an ultrasound, Doppler, and a CT angio for the patients. But I would think that the common trunk could cause compression just as easily as someone with more normal vascular anatomy.
Okay. Someone wants to know if that you mentioned a pancreatic cancer surgeon, and somebody had had a consult with them, and he said he treated SMAS, and she wants to know is a pediatric cancer surgeon a good option?
A pediatric surgeon who does a lot of cancer is probably very experienced and would be technically very good at this. Um, even those of us who are kind of do SMA syndrome a lot, we don't, it's not enough to sustain a practice. So we do a lot of other things as well. So yes, I could see that a person with that background, having a reasonable amount of experience, but I would counsel, it's probably worth, getting more than one opinion, um, just to make sure you're doing what's best for you.
Right. Okay. Thank you. And somebody else would like to know if your surgery would interfere with future endometriosis surgery, such as diaphragmatic endometriosis or liver mobilization for endometriosis behind the liver. Would it be possible to safely inspect all segments of the bowel for endometriosis, or would that be risky?
I mean, for a lot of the gynecologists that do endometriosis surgery for things like liver disease and diaphragmatic disease usually get a general surgeon involved. But you can easily run the intestine looking for endometriosis. Um, you can do that through a minimally invasive robotic or laparoscopic strategy, and you can pretty safely evaluate the intestine. Endometriosis can be hard to diagnose just by visual inspection, and so you might miss some disease if it's very small, but I think it can be safely done.
Okay,
It's not like you undo your work, your surgery, your procedure that you performed.
Mhm.
It's not like you undo it. Like I'm afraid like they have to inspect their bowel, that they undo some certain fixation points that you performed.
I think it would be, so the transverse mesocolon is very thin and be easy to see through. I think if you tried to do that after my procedure, it would still be, you'd still be able to safely evaluate the intestine fully.
Okay, thank you.
Sure.
You're
If
in Texas, right? You're in Texas?
Correct.
Okay. I'm from Belgium, but hey, who knows? Thank you.
Oh, you're welcome.
so here's another question. If a patient has mild gastroparesis, like 17%, do you feel that that's possible SMAS or true gastroparesis? So what percentage of patients have gastroparesis after surgery, or what percentage goes away?
Well, so the problem with gastric emptying studies is they sometimes don't, it's a nuclear medicine study, which is not entirely, it doesn't show the anatomic details all that well. And so it's hard to tease apart a gastric emptying study. It's hard to tell if there's gastroparesis when there's a proximal duodenal obstruction as well, like for instance, from SMA syndrome. And so I typically don't put a lot of weight into a gastric emptying study if there are signs of SMA syndrome. Differentiated in my mind is if there's delayed gastric emptying and the duodenum's very generous and large on the CT scan or upper GI, I think that's highly more likely to be related to SMA syndrome than if the duodenum's small and there's not an obvious obstruction on the CT scan and the stomach's just very big and then there's delayed gastric.
That's interesting. Yes.
It's hard to tease apart, but I think the gastric emptying study can be a bit of a red herring because gastroparesis is far more common than SMA syndrome. And so it's typically going to be read as gastroparesis if there's delayed gastric emptying.
Okay. And here's someone who's had a revision and they want to know if their dumping syndrome will ever resolve.
Uh, you know, typically dumping syndrome is managed with diet modification, time, and sometimes it gets better, sometimes it doesn't. If there's significant dumping syndrome, a revision to kind of a Roux-en-Y partial gastrectomy may be necessary, but even that may not relieve the symptoms. And it can be very difficult. That's why I've kind of shied away from doing very large, wide open anastomoses, but it can be tough to deal with.
Okay, thank you. There's one more question here. What percentage of your patients have been labeled with depression or some other mental condition before being diagnosed with SMAS, and how do the mental symptoms respond after surgery?
I think the mental symptoms, when things like chronic PTSD can certainly lead to symptoms of depression. Feelings of hopelessness, things like that are pretty common. Particularly for patients that have been dealing with this for a long time. But even I've seen it in patients that are just dealing with it for a couple of months. If they've been to 2 or 3 different doctors who told them it's all in their head, then they think, well, maybe it is all in my head, and they train themselves to kind of lose hope. So I think it can present in the short term or the long term, and having long-term symptoms doesn't necessarily mean you're going to be depressed about it. But I think there's some depressive symptoms that overlap, and some feeling of hopelessness is pretty common in patients with SMA syndrome. I think if in patients resolve quickly, they frequently, I think, feel better pretty quickly, but I think there's still problems with mood and things like that have been kind of partially trained into the brain from, it hurts every time I eat and I can't, and I think it gets built in a little bit and needs to be treated as a separate problem after resolution of the obstruction.
Okay, thank you.
Well, thank you so much for spending your afternoon with us. We really appreciate it. And
We really do. Thank you very much.
Again, I learn more from y'all from seeing patients and asking them about their symptoms and how they've managed to survive, without being able to eat for a long time. I learn and I am really inspired by a lot of people who just push through and keep looking for answers and keep looking for answers. And I wish I could have a procedure that worked 100% of the time and I could guarantee it, but this is a hard problem to deal with. And thank you guys for supporting those of us that really want to help people get better. And I think it's just an honor to get to talk to y'all today.
well,
Okay,
yeah,
we
there's one
really
more
appreciate it. There's one more question, actually, that just came through. Somebody would like to know why, in your opinion, your DJ revisions aren't working.
Boy, if I knew the answer, I would figure I'd be one step closer to figuring out how to make it work. I think part of it is there's in patients who have partial obstructive, when the DJ doesn't offer any relief, I think it's probably because there's some underlying GI dysmotility or for some other reason that things aren't moving through. So I think it's probably that there's some other cause of the symptoms in addition to the obstruction, and fixing the obstruction doesn't solve the underlying problem. And I think that's why they don't improve.
Well, we need research on that, and whoever we can get to do the research to figure out how to fix the motility issue, that's going to be the real answer, because you guys can fix the structure, but once that's fixed, then we have to be able to get everything working through the tube that you guys fixed, because you can fix the plumbing, but we got to make everything go through.
Sure.
So,
I would encourage y'all, if it's really hard to know who's good and who's very interested in this. Dr. Alvear folks, Stevenson, Cruz, those of us who do this, we kind of know who each other are.
mhm.
Some of us have a little more frequent interactions than others, but like there are GI doctors that are good at dysmotility, but I don't know who they are. Like we don't have a great dysmotility service here. I have patients that kind of seek care and all over the country. And if someone figures out a good team that's helped them, I would love to hear, if there's somebody I could refer my patients to for other GI type problems. Be very interested in getting that feedback.
Okay. Yeah, we work with the IFFGD, and they're in Washington, D.C., but trying to get GI doctors to, get on board is very difficult. So, I mean, our patients are the best to help you with that. And so hopefully we can shoot some names your way.
Yeah, I think that'd be very helpful. I appreciate that.
Yeah. And I'm up in North Texas when you were saying you had a storm coming, and I'm like laughing because
Well, Houston, if it just gets cold here, the whole city shuts down. Like we'll lose power, water will stop. I don't even understand how.
And we got like, I don't know, 4 inches of ice outside my front door. But anyway, yeah. But okay,
How far away from Wichita Falls are you?
What's that?
How far away from Wichita Falls?
A few hours.
Okay.
Not too far.
Well, it's a good, I'm in Northern California, but my son lives in Wichita Falls, so it's a possibility that it would be a good practice.
Oh, okay.
But there's nobody in California.
Oh, he's Dr. Southard down in Houston.
Right.
Wichita Falls is not. I get several patients from the Dallas area. Wichita Falls is not too far outside of Dallas.
Yeah.
And it's actually easier. It's easier to treat somebody in North Texas than it is somebody in Louisiana, which is very close to Houston because of the, laws and trying to call in prescriptions across state lines.
Right.
Problem. Yeah. The doctors in California don't seem to want to treat, because I'm kind of a problem.
my medical record chart is huge, and they just want to pass you off to the next doctor for the next thing and don't want to spend the time. So
yeah.
we keep being pushed out of state.
Yeah, I've had a few patients from California that I get that feedback. I mean, there's I guess Dr. Schuid's
Yeah, I had mouth surgery with Dr. Schuhead.
yeah. Yeah, I don't interact with him very much at all, but I mean, I don't have his number like I do Dr. Stevenson's, but
Yeah,
you know, if you can make it here, I'll be happy to take care of you.
wonderful. Thank you.
You're welcome.
Always welcome in Europe also.
All right. Well, thanks again, everyone. I again appreciate the opportunity to talk to y'all, and I'm more than happy to learn what I can and keep working towards finding the best solution possible for this problem.
Thank you, Dr. Southard. We really
Thank you.
appreciate your interest in this patient group. Thank you.